BiPAP. You want to watch for your CO2s. If you have a patient that has a CO2 in the 40, in that 45, 50 range, and their pH is normal, and they're breathing kind of normal, they probably live there. If you have a patient that's breathing 38 times a minute, and their CO2 is 60 and their pH is 7.3, those are red flags, and that's why I like to get that base gas to see where your pH is, to see if they're compensating or not. They can compensate for a while and that CO2 still not be high, and if their pH is not going that the direction to become acidotic, once they tire, they'll drop quickly. And once they get tired, then the pH will change. So that's where it's that balance, and I'm glad to see we're doing a lot more gases with these patients to kind of see where they're at and to hopefully get some of that stopped before they get as bad, and we can get them on BiPAP and things like that a little quicker. Of course, you talked about the bronchodilators and doing all the things to try and get secretions out of the lungs to get them better ventilated and treating the infections. When you have a patient that's mouth breathing, most of the time it's okay. They get oxygen in the nose and it pulls in, and it's it's not bad. But you get somebody that has a deviated septum, or there's a lot of nasal congestion or different things that are going on, and it's just not going through. So you kind of have to just use your eyes and common sense. They may have to go on a mask because they're not getting any oxygen through their nose, so they may need to go to a venting mask. Just and then switch to the cannula for meals or something. So you have to look at those points too with the patient. And this is our vision. The vision, I can go up to 100% with this. So if we have a patient that is doing bad, isn't oxygenating, I can hook this in and we can do it. Thing is with this, you want to look at and get your patient to the place that catch them before they get too bad. This can stop patients from having to be ventilated. You can stop the failure before they get to that point of needing to go on a ventilator. Not always, but if you're going to give the patient a chance, this is the best way to do it, is by getting them on. I can adjust the settings so that it works with the patient, and I watch them breathe to see how it makes it best. A little bit of end expiratory pressure that kind of distends the alveoli in the lungs to hold them open, and that positive pressure to help them move, to take their breath, so that it's not so hard to get the air in. And a lot of times this will get them turned around really quickly. Gas exchange, arterial blood gases improve because of the increased alveolar ventilation, and it reduces the work of breathing when you're using the BiPAP. Contraindications, well, big one, you don't want to use BiPAP if they're in respiratory arrest. Not going to work. So these are some of they're basic, and when you look at a patient, you can kind of tell, are they going to work? If you have somebody really confused, they won't keep the mask on, or they're unconscious, you don't want to put a mask, full face mask on somebody that could vomit and aspirate, things like that you're going to look at. If they have a lot of trauma, those types of things you're going to look at, if they're able to cooperate and use the mask. One of the things that it does do, and what I try to do if I'm going to have somebody, is I put, and I can't think of the name of it, it's that little spongy stuff that, what I'm talking about, that I always try to cut a little piece of that, because
Mhm.
one of the biggest things with BiPAP mask is you get breakdown really quickly. And there's been a lot of, other places have had a lot of nasal reconstructions and things done because of breakdown on the nose from BiPAP. So I like to get that on right away to watch that, so that, we don't get that breakdown. And to even take it off for, you know, a couple minutes or something to release that pressure. The BiPAP doesn't have to be tight to get a seal. That machine will push out the flow that it needs with a fairly good sized leak. You just don't want it leaking around the eyes. Anybody have any questions? That's kind of a